Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community, our province, and the country. Today, we are delighted to partner with Solutions for Kids in Pain, or SKIP, to bring you our commitment to comfort, spread and scale of a pediatric pain management initiative. Just a reminder that we record all our webinars. As mentioned in the introductory video, please type your questions into the question box at any time. I'll prompt you via the chat as well, and I'll pose the questions to our speakers at the end of the session. Now I'd like to introduce our speakers for today. Dr. Samina Ali is a pediatric emergency physician at the Stollery's Children's Hospital in Edmonton, Alberta, and a professor of pediatrics and emergency medicine at the University of Alberta. Dr. Ali is the Western Canadian lead for the National Knowledge Mobilization Network Solution for Kids in Pain. Dr. Elise Ryder is the knowledge broker for the Western Hub of the Solutions for Kids in Pain, based at the Stollery and Department of Pediatrics at the University of Alberta. Dr. Ryder is passionate about co-development of knowledge translation initiatives with patients and families and helping to amplify the voices of underrepresented groups. And Dr. Jennifer Toole-Friedman is a pediatric emergency physician and the medical director for quality and safety at the Alberta Children's Hospital in Calgary. She's also the physician lead for quality in Alberta Children's Hospital Emergency Department and a clinical associate professor in the Departments of Pediatrics and Emergency Medicine at the University of Calgary. And it's my pleasure now to hand the virtual mic to Samina.
Thank you so much for that wonderful introduction. Oops, my apologies. Thank you so much for that wonderful introduction, Paula, and for welcoming our team to talk to you all today and discuss about commitment to comfort, spread, and scale of a pediatric pain management initiative. We're so excited to be here, in part to tell you what our experience was, but to learn from everyone who's attending more tips, more tricks, more ways to effectively improve children's pain across Canada. So in terms of disclosures, as you have heard, Dr. Toole-Friedman is the Medical Director of Quality and Safety at ACH and is the project lead for the Emergency Department Commitment to Comfort that we'll mainly be talking about today. I work with SKIP and was also the content expert for the ED Commitment to Comfort team led by Dr. Toole-Friedman, and Dr. Ryder is a knowledge broker for SKIP as well. So those are the lenses with which we come, but no financial disclosures to make. So today, just before I turn it over to Dr. Ryder to walk us through our information, we're going to try to relate to you so that you're comfortable naming the pillars of commitment to comfort and appreciating they're based in current evidence. So whether you memorize them as the commitment to comfort pillars or not is not the point. The point is that they were all drawn from current best evidence, and that they represent the different facets of pain management that we should be using when we care for children. Second, understand how this type of initiative can be spread and scaled outside of tertiary pediatric care centers to other settings where children are seen and treated. In the emergency world where I live clinically, the number that we often hear is 80%, that 80% of children are seen outside of pediatric centers for their emergencies. So it starts to feel a little bit short-sighted to only focus on our pediatric health centers. So this is a way to help us expand efforts to where the children are, so to meet the children where they are. And then lastly, recognize and overcome common barriers to sustainability of grassroots quality improvement initiatives. So this is going to be half information sharing and maybe a drop of therapy for us as we talk about the things that went well and the things that we would do differently next time, in hopes that your teams, if you're embarking on similar work, would be able to learn from this and make perhaps different decisions or modified plans. I'll hand it over to Dr. Ryder now.
Thank you so much. I'd like to start off by just taking the opportunity to thank all of you for attending this webinar on commitment to comfort. And I will just start out by introducing the initiative and providing a little bit of background on it. So we can go to the next slide. Great. So Commitment to Comfort is a quality improvement initiative that was initiated for the emergency department at Alberta Children's in Calgary in 2014. This initiative was developed by a team of physicians, nurses, and child life specialists, including Dr. Toole Friedman, who sought to improve children's comfort and reduce their pain when receiving care in an emergency setting. So this initiative has received a number of awards, including, as you can see here, the 2017 Patient Experience Award from the Health Quality Council of Alberta. And we'll go to the next slide. Thank you. So it perhaps isn't surprising that the treatment of pain is a high priority for children and their families who present to the emergency department, as many patients who seek emergency care are either experiencing pain or perhaps will experience a painful procedure. Current research has demonstrated that untreated or undertreated pain can cause harm for children. Children whose pain isn't adequately managed may experience a longer healing time and longer hospital stays, and they may also be at risk for experiencing more complications as they heal. Outside of the initial reason children or youth are seeking care, undertreated and untreated pain can also have long-lasting effects. These children may be at an increased risk of developing a fear of needles, which can develop into a phobia for a small proportion of children and youth. And it can also make them more likely to avoid care when it's really needed as they get older, or they may need to access care more frequently. Knowing this, when the team at Alberta Children's investigated further into the treatment of children's pain in 2014, they found that only 32% of children with a limb injury received pain medicine, and 18% of children and their families were dissatisfied with the pain care they received. The team also found that topical anesthetic was being used inconsistently, and its use was not being regularly documented. Next slide, please. So, in order to improve children's comfort and pain management in the emergency department, the Commitment to Comfort program was developed, and it's currently based on 6 pillars: making a comfort plan, applying topical anesthetic, using comfort positions, breastfeeding or using sucrose for infants, using distraction, and using positive language. These pillars are evidence-based ways of improving children's comfort, lessening their pain and anxiety, and empowering patients and their families to take an active role in the child's pain care. They focus on different aspects of the 3 Ps of pain management: physical, psychological, and pharmacologic interventions which, when they're used together as part of a multimodal pain strategy, can help create a positive experience not only for the patients and their families, but the healthcare providers involved in the patient's care as well. Next slide, please. As you can see here depicted on this slide, the Commitment to Comfort program has a number of resources that are available for the emergency department setting. Some of these resources include posters, which include information for patients and families about how to do comfort holds and how and why to use a numbing cream. These tools encourage caregivers or other family members to speak with their healthcare providers if they feel their child's pain isn't being adequately managed, or, for example, if the numbing cream isn't being applied for the right amount of time before a needle poke. Resources also include a bookmark for patients and families, which includes 2 pain scales, the FACES Pain Scale Revised and the Stoplight Pain Scale. As you may be aware, the FACES Pain Scale Revised is a tool to help children self-report their pain intensity that can be used for young children. One of the advantages of this scale is that the 0 to 10 metric along the bottom can correspond with the numerical self-rating scales that are commonly used for children over the age of 8. The Stoplight Pain Scale is also a useful scale that can be used for children that directly corresponds to an action that the caregiver or healthcare provider can take to help manage the child's pain. For example, a child who rates their pain as a yellow may not need something to help manage their pain right then and there, but they should be asked again shortly. A child who rates their pain as red would be asking for an immediate intervention to help manage their pain. Also included as a resource for the emergency is a brochure that contains a lot of useful information for caregivers in the bottom right-hand corner of your screen. So in addition to the Stoplight Pain Scale, it provides information on how to manage pain at home and provides caregivers with the tools to initiate a conversation with their child about what they would like to help manage their pain, whether it's a pain medicine, numbing cream, ice pack, or something to help distract them. Patients themselves or their family member can then communicate this information to the healthcare team. Emergency departments that adopt Commitment to Comfort also use these distraction kits, an example of which is seen in the upper right-hand corner of your screen. These kits include items to help distract patients during procedures, and they can actually be quite flexible in their makeup, including things like fidget spinners or light ones. So I'm now going to hand the presentation over to Dr. Toole-Friedman, and she'll discuss how the team at ACH has led this spread and scale of Commitment to Comfort in emergency departments across Alberta.
Thank you, Elise. I'm really excited to talk about this morning. This project has been really fun and satisfying for those of us who have been involved, and I always enjoy sharing it. Next slide, please. So I'd like to talk a little bit about how the program got started, and I'll talk about how we used a scale-up framework to conceptualize how we would go about spreading. And I'm just going to say, when we started our program in 2014, it was myself, another physician, and 2 nurses in the emergency department that were the core team. And we started out being aware that in general, children's pain is often undertreated in emergency departments, and we really didn't know how well we were doing. We kind of had the idea we were doing okay, but we weren't measuring. And so we started looking at our own patients and how well we were doing. And the way we started in the very beginning was we made a simple survey and we gave it to 100 patients who came into our emergency department with a limb injury, just to understand where we were at. And that's how we learned that 18% of those families said that they were dissatisfied with their pain care. And we also wanted to know, what should our targets be? What proportion of these kids with limb injuries should have analgesia? And we thought that number should be very high. We did learn that actually 1/3 of the patients were receiving analgesia prior to coming into the emergency department. And the number that actually wanted to get analgesia from us, when you subtracted the ones that had already received treatment and the ones who had actually minor injuries and said they were comfortable and didn't need anything. Our target number actually that we began with was 40%. We've revised that to 45%. So lower than expected, but the whole purpose was to be patient and family centered and to understand what our patients' needs were and to meet them. So having that local data was really important, and it was pretty quick and easy to collect it. With that in mind, we started developing our scalable unit, meaning we wanted to kind of develop the prototype to first fix what was going on in our very own emergency department before spreading. And when we started out, I think we used a lot of sort of our logical left brain skills, and we thought, okay, first step, everyone should have a pain score in triage. And yes, they should. But we found we weren't really engaging our teams around that. And things were pretty slow to go. And where things really took off is where at one meeting, we decided to make something called a key driver diagram and essentially figure out what factors would contribute to our success or failure. And one of the things we thought about was patient and family engagement. And once we thought about that, the program really took off, because that's when we said, let's develop a public-facing component to this. Let's have a name. We decided to call it Commitment to Comfort. Let's have a philosophy on it that we will do our best to reduce pain and distress for all of our patients. And let's attach a little bit of fun to it, a little bit of branding. We had a small amount of money so we could have the cartoon characters drawn. Everything that you saw in the slide that Elise shared, for the most part, was done by the team of 4 of us, with a lot of communication with Samina saying, Samina, what should we be putting on this stuff? And that's where it took off. So we focused first on our own emergency department, and what I want you to take away from this particular slide is that if you are thinking of scaling up, to start getting that first unit right. When you get it right, you then can test the scale up, and it's recommended that to not go up by maybe more than a factor of 5 for each scale up. And so then when you have things going well in a few locations, that shows that your scalable unit can be successful outside of the original unit. And then you're ready to multiply, again, usually by about a factor of 5 every time you go up. And so this is the principle that we used. All right, next slide. And so what we did was we started out by focusing on limb injuries, because it's such a common painful condition in children visiting emergency departments. About 14% of children's visits to emergency departments in Alberta are from limb injuries. So after we were doing well at the Alberta Children's Hospital, we had actually reduced our time to analgesia at the Children's Hospital from about a half hour down to 9 minutes for those kids with limb injuries. And we had increased the proportion who received analgesia to over 40%. So we then spread to the Calgary area general emergency departments. And we did that by asking each emergency department to develop their own team. We really wanted it to be locally owned. So we suggested they all have at least a physician, a nurse, and some of them had orthopedic technicians. And so we wanted them to put together their own team. And then we shared with them the tools that we had developed. And we said, modify this, use it for your context. One emergency department didn't have a scale in triage, and that's why they weren't giving kids pain meds early, because they didn't know how much they weighed. So in that context, that was an important intervention that we had not done in ours. So that locally owned approach, I think, really made a huge difference. And as you can see, we actually were successful in children's visits across the city of Calgary to improve the proportion receiving analgesia to above our target, and also reducing the median time to analgesia around the entire city from 37 minutes down to 12 minutes. And we had the benefit of having an electronic health record to be able to understand this data. Next slide. So then when we wanted to spread to the whole province, we had to think about how we would do that creatively, because then we were moving to emergency departments that did not have electronic health records. And we wanted to give every single emergency department in the province an opportunity to participate if they wanted to. And so there were 97 emergency departments in Alberta that had not yet participated, and we invited all of them to be in a quality improvement collaborative. And we said to them, if you would like to participate, we will ask that you form a project team that's multidisciplinary. We will have webinars once or twice a month to learn a little bit about pain treatment and a little bit about QI methods. We wanted them to develop their own aims and to test some of the changes in plan, do, study, act cycles. And we asked every emergency department that was participating to commit to auditing 20 charts per month, 10 from children with fractures. And we decided to add at this point use of topical anesthetic as another measure, because what we learned is no matter how awful a child's fracture was, they still wanted to know if they were going to have a needle and if the needle would hurt. So as we spoke to patients and families, we learned that having a measure of reducing pain with needle procedures was very important. So how did we do this when we needed to reach the whole province? Well, we were able to identify fracture visits in the province using diagnostic codes. And we were able to identify our group of children who should have had topical anesthetic by looking at blood work that was done in the emergency department. And we decided to use children 0 to 12 years of age for this group. And so we were able to get essentially access to all of the children who had received blood work in Alberta emergency departments. We then sent to each site a randomized list of 10 kids who had fractures in their emergency department and 10 kids that had blood work. We asked them to then go pull those paper charts, and we made a very simple online survey using a tool called REDCap, but just a simple online survey. This took them less than 30 minutes per month to go get the paper chart and look at whether or not the child got topical anesthetic. Did the kid with fracture get pain medicine? They put it into this very simple survey, and we were able to put those into these control charts to see how well we were doing. So every site was able to see their own data. And I think that was so key, because if you don't know how well you are or are not doing, it's so hard to improve. So every site could see their own performance, and then we could put it together in a provincial dashboard, and that'll be on the next slide. And so this gives an example of what we were able to see and do provincially. So 36 of the sites accepted our invitation, and they did represent all of the geographic zones of Alberta, from southern Alberta up to way up north, communities that honestly I hadn't heard of before this collaborative, and representing 40% of all pediatric visits in the province. And using these small teams in rural community hospitals who agreed to do 20 chart audits per month, we were able to look at over 8,400 child visits across the province. And 23 of the sites completed enough audits that we were able to look at their data before and after we did tests of change. And we were very pleased that we went from a baseline of only 10% of children receiving topical anesthetic across the province to 30%. So not quite our aim, but a substantial difference and a real start toward culture change. We were also able to reduce time to analgesia for children with fractures from an hour down to below 30 minutes. So we were really pleased with the results. Next slide. And I think the last thing I'll say before transitioning is just that we received a lot of feedback from the teams that worked in these small community hospitals, and they really enjoyed being able to participate in a project like this. We heard from some that it was the most fun project they had participated in years. They really liked being able to do something great for their pediatric patients. And I think that local ownership was a real key factor in the success. Thank you.
Thanks, Jennifer. So as you've seen, spreading and scaling commitment to comfort through emergency departments has been one way in which we can ensure children and youth in Alberta are receiving a consistent pain care experience, regardless of where they access their care. The principles of commitment to comfort can also be adapted to non-hospital settings as well, which I'd like to go into a bit now. To start off with, I'd like to highlight some of the work that Alberta Precision Labs has done in order to manage pain in their phlebotomy labs. Next slide, please. For those of you from outside of Alberta, Alberta Precision Labs, or APL, is part of our provincial health authority and delivers lab services across Alberta Health Services and Covenant Health facilities in the province, as well as in the community in parts of Alberta. APL has worked closely with AHS and the team from Alberta Children's to adapt commitment to comfort for use in a laboratory setting, and then has successfully scaled and spread the initiative to all of their labs. Their work with commitment to comfort focuses on encouraging caregivers to use positive language, distraction, and comfort positions, as well as to learn about how to use topical anesthetics before lab procedures. In order to help facilitate this, APL has a number of resources publicly available on their website for families, including a brochure on commitment to comfort for the lab setting, a guide for how caregivers can use positive language, and a comfort care plan that kids and their families can fill out prior to getting lab work done, as well as information on how and where to purchase numbing products before arriving at APL. Next slide, please. I'd also like to highlight one of the pain management initiatives that is occurring in public health centers in Alberta using a program called Positive Immunization Experience, or PI, as an exemplar. Next slide. Before I start, just to be clear, PI is not part of the Commitment to Comfort program, but it was developed independently in the Edmonton Public Health Zone around the same time. PI originated in 2016 at Westview Public Health Centre in Stony Plain, Alberta, as a way to improve children's immunization experiences. But this program was initiated around the same time as Commitment to Comfort, demonstrates an increased understanding across the province that children's procedural pain management is important and that steps need to be taken to help manage kids' pain and anxiety during these procedures. In a similar way to Commitment to Comfort, an integral part of the PI program is to help empower patients and their families to learn about how to manage pain and advocate for proper pain management before potentially painful or anxiety-inducing procedures such as immunizations. Next slide. So the PI team is currently working on spreading and scaling their initiative through provider education across the Edmonton zone, which includes 21 public health centers across the greater Edmonton area, as well as the schools that these public health centers are responsible for. PI also takes an evidence-based multimodal approach to pain management and includes physical, psychological, and pharmacologic pain management strategies with a specific focus on helping to prepare children and their caregivers for immunizations, as well as ensuring staff are well trained to consider pain and anxiety during immunizations and how to manage those. Next slide. So next, I'd like to circle back to the emergency department setting where Dr. Ali and I are working together with a team to revitalize the implementation of Commitment to Comfort in the emergency department at the Stoplight Children's Hospital in Edmonton. Next slide. So Dr. Ali and I have been working with a multidisciplinary team to relaunch Commitment to Comfort at the Stoplight. And our team includes physicians, a nurse champion, a child life specialist, and myself as a knowledge broker. We've been meeting on a regular basis since the fall of last year in order to plan the relaunch of our program, including considering how we will collect and analyze chart data related to pain and the use of topicals for needle pokes and laceration repairs, how we can best educate physicians, nursing staff, and patients and families, and how we can reintroduce some of the resources I showed at the beginning of this presentation, such as posters, bookmarks, and brochures. So our aim with this relaunch is not only to improve patients' pain and anxiety in the emergency setting, but also to help us create strategies on how to spread commitment to comfort to the entire hospital at the Stollery. I'd like to now turn it over to Dr. Ali, who will discuss some of our lessons learned and future directions for this project.
Thanks, Elise. So I thought I'd spend the last few moments of our speaking before we open up the discussion to all on the call to talk about what we learned with our first implementation of commitment to comfort in our emergency department. So at the time, it was a little bit of a blind leading the blind situation locally. Now, we had fantastic guidance and knowledge shared with us from Dr. Toole Friedman and her team. But at the end of the day, in our emergency department, we were muddling our way through it, trying to figure out how to do this. And at that time, we had one physician and one clinical nursing lead. And because of that combination, and the way things are often designed, these individuals were volunteers. And so when they became busy, when they had a leave or a vacation, we didn't have a safety net. And so things would sometimes have to pause. In fact, during sort of mid-implementation, one of the physician lead ended up taking a position in a different hospital, which happens. And we wished her all the best. And then we had to very quickly identify and get someone else new up to speed. So those were some of the challenges with having one individual only representing each pillar of care in the department. We also didn't include other important pillars within the department, which I'll get to shortly. As I said, neither of these individuals had protected time to focus on implementation, and dedicated people can do incredible things, and it's also a big ask, right? So we have to always think about that and what that means. Can we integrate people into our team who have paid and protected time to do this work, if possible? Widespread support of commitment to comfort in the ED without this protected time really was a challenge. Now, does this mean that you have to have an individual who's paid specifically only to work on commitment to comfort? No, because I don't think that's realistic. But if you have somebody, for most people and most centers, but if you have someone who is a part of a position that includes quality improvement and or education as their core responsibilities, then that person can justify spending time on this project as a part of their regular daytime work hours. And that's where you then have that so-called protected time to do this work. We learned a lot about our distraction kits because we love those distraction kits. We love the concept of having a transportable, easy to move plastic bin that was easy to clean, that we could share across the department. But what we learned was, as our department, over the implementation of commitment to comfort, we were very fortunate to have more and more child life presence in our department, being a pediatric tertiary care center. And as we had increased child life presence, they bring their own tools and in some cases, many cases, toys as well. And our commitment to comfort items were getting mixed up with theirs, and theirs were getting mixed up with ours. And so over time, those kits that were full of distraction toys became much lighter and were missing items. We also have a high volume of patients. So Stollery pre-pandemic was seeing 60,000 patients a year. And so use of these toys, which are only so durable, ended up with toys that were broken, and unless we were really on top of replacing and monitoring those kits, it became a challenge. Kit maintenance really needed creative strategies. So we needed to figure out ways to check on them or have them highlighted to us as needing to be replaced. We needed to think about what might be more sustainable, what toys. We learned a lot about toys and what works well, what you can drop without breaking, that kind of thing. So we did have to think about how to keep the kits stocked and functional. And as we actually moved on, we in our new re-implementation phase that we're in now for the stollery, because we have a greater child life presence now, or in great part due to the fact that we have this greater child life presence, we've actually not elected not to restock the kits, partly because of other things that are available, and in great part due to the pandemic, which I'll get to in just a moment. So use of distraction kits may be much more sustainable in smaller departments. When I've spoken to some of the programs across Alberta and the country who have adapted this distraction kit concept in general emergency departments, they've actually done far better than us in keeping it stocked and protected and used. And I think it's because of lower pediatric volumes. So all this to say, the distraction kits have a tremendous role, particularly in departments where you don't have child life presence or have or are pediatric focused, because then the department itself is probably set up a little bit differently. Then 2020 happened, and we were in the middle of planning this re-implementation, and all of a sudden everything changed. So a great example is Bubbles. Anybody who loves children and loves working with children and has ever been step foot in an emergency department knows that Bubbles are often our greatest ally / weapon. And of course, in the context of a pandemic that is driven by a respiratory virus, blowing into people's rooms or close to their faces was off the table. And up came this great idea of bubble shooters or bubble guns. So we actually spoke to our infection prevention and control colleagues and showed them this bubble shooter you see on the screen, and they agreed that we could bring this one in. So we now, as of this week, have these IPC approved bubble shooters at our nursing desks. So they're not for the patients to use, but they're for the nursing physician and other staff that are interacting with the children to take in to distract them during vital signs or procedures. So we're pretty thrilled to have those throughout. We've also identified a way to purchase more spinners. Those light spinners, with the fiber optic lights, are just children seem to be mesmerized by them, and they're in constant short supply in Alberta. But we found some, and we've decided to tether them. There's one thing we learned from our distraction kits, where those were the first things that went missing because they were so beloved, I think, and so enjoyed, and they may travel up to the wards with the child or whatnot. So we're going to tether them at triage, where our nursing colleagues found them extremely helpful. We're reinforcing topical anesthetic use again, because while we have definitely talked about it, educated people, we saw the uptick when we did the first wave of commitment to comfort, the first implementation. We wanted to make sure that it was still happening and that it was being used not only for our youngest patients, but also offered to some of our older ones, because we had anecdotally, while working clinically, our team had heard things like older children don't need it, and that it wasn't being offered to older children. We thought, well, there's evidence to support its use, and it should be a choice, part of a child's decision making about their comfort plan. So if they wish to have it, they should have access to it. We've revamped some of the posters to make them family facing, and of course, continued engagement of child life services. And we are so fortunate to have individuals on our team now who are so engaged, both on the clinical side as well as on the quality improvement and research side. And so we're not only engaging them more day to day with patient interactions, but also in the planning of quality improvement initiatives. So we now have a child life specialist on our team, and also on our research end. And then sustainability. How do you keep things alive? How do you keep them going? How do you keep people excited? So this time around, 2.0, we focused on developing a multidisciplinary team. And so, of course, we included the usual suspects. So our physicians and nurses were there since they would have a lot of contact with the children. But at this point now in 2020, we now had pretty consistent and permanent child life specialist presence in our department. And we knew right from the start that having them at the table would be so informative, so important, and also help sustain the efforts because they are so involved in the comfort and pain management planning of the children in our department. And I remember sitting around the table with this team one day and sort of, almost doing a head count of people we interacted with. And I think on any given shift, our child life specialists, I can say with some certainty, see more children than probably most physicians and nurses in terms of head count. So they have an opportunity to influence the healthcare trajectory of so many children. And so we're so thankful that our child life specialists are on board to be part of the team this time. We also chose a nurse champion. Our first round, we had a nurse educator, a nurse administrator, who was absolutely, in theory, our biggest champion. But the individual we chose, and I think this is a common mistake to make, is that we chose someone who was very, very, very busy. And so while they were fantastic to have to help disseminate information, know how to get the information to nurses and physicians, they didn't have a lot of time to give us to help us develop better on the ground, on the floor plans. So that's where our nurse clinical champion was so important. And having a team member dedicated and with paid time, protected time for the project was so important. And that's where having Dr. Ryder was critical to helping us have the time to develop this, think about it, and implement it in a meaningful way. So we were so fortunate to have someone who had a knowledge broker background and training to come and help guide us. Now, I know that's not the privilege of every center, but getting guidance from a QI expert on in your institution or in your setting is probably accessible to almost everybody, because I think at this point in time, if you are working with an affiliation or at a hospital, any hospital, they would have a quality improvement individual. If you're in a private or smaller clinic, that may not be the case, but I would hope through connections and affiliations, you'd be able to get guidance from a QI expert. And then the biggest lesson of all was culture change takes time. And to expect setbacks and challenges. And I think I was a little bit naive this way, where, I was so believed in what we were doing that I couldn't imagine any scenario where it wouldn't be immediately and completely taken up by our team. And I'm sure many of you are laughing at your screen right now as I say this. But now, I recognize that it's not about just intentions. It's not about understanding the evidence. There are so many things that can make it challenging to change the way we have always done things. And so to be patient and expect setbacks and challenges and see them as that challenges, not roadblocks that prevent us from moving forward. So I'll stop there and say merci and thank you to all of you on behalf of our team that presents today, plus everybody else who is a part of this project. And I'll turn it back to Paula and our team at Children's Healthcare Canada to curate any questions or comments that you might have. We would love to hear your experiences and thoughts. Thank you so much.
Thank you all, Samina, Elise, and Jennifer. We do have a number of questions, so I'll get started. Doreen asks, do you still encounter some resistance using analgesics with regard to time constraints as a reason for not using them?
Yeah, thank you for that. And I'm sorry, I'll just say to my team members, please unmute yourself and jump in at any point if you have something that you wish to contribute. Yes, absolutely. We did encounter that in the emergency department. We were fortunate that we were able to have nurse-initiated protocols for the topical anesthetic application. So when we empowered our triage nurses to apply it at their discretion, that became less of an issue, so that if they anticipated a child needed blood work or an IV, they might apply it right at triage. And so then that 30 minutes of having the cream on would transpire often before the child even got to a room in the actual department. But if it hasn't been applied and there's unanticipated blood work or IV requirements yet, we still do sometimes get some resistance. And that's where I think as champions on the floor, we have to navigate that to say, that's okay, let's put the cream on. Why don't we do the x-ray first and then come back or something like that? But yes, this is an issue. So that's part of the culture of get her done, right? We're great at that in the emergency department.
Samina, I'll just add to that. One of the things that I think has helped with that is when we put those public-facing posters in all of the treatment areas. And I think the slides included a couple of those, but the kids with their topical anesthetic patches on, and with the language of the posters directed toward families, saying, is your child having a needle procedure? And so when families know that it's available, then it really helps, because if we have either not noticed that a child is needing it or will need it, or we, of course, have some people that are less enthusiastic about taking the time, as has been mentioned. But when families know that it's available, I've found that that makes a big difference.
Thank you. Mariana asks about the training that staff in the emergency department received as part of the implementation efforts, and was education provided to any other sites in other communities?
Yeah, so we had with the provincial spread, we had monthly webinars that were 1 hour, and we would spend about half of the time on the QI methods and the project details, but half of it was on the content of why it matters to take care of children's pain. Sometimes it was about what language do we use when we're talking to children about pain or procedures. Some of it was, which medications work. How do we do these? How do we do comfort positions? So we had those webinars. We recorded them. We made some short versions so that people could watch a 20, 30-minute video. And then we asked all of the participating emergency departments that to then share with their staff, so they could either share a video or they could learn the content themselves and share it verbally, which is actually what a lot of them did in these very small emergency departments. They would just talk to their colleagues during shifts. They made some communication boards and posters, and the sites were actually quite creative. And I actually found that sometimes culture change happened faster in these small emergency departments than in the larger ones. And, they didn't have child life specialists and so forth. And yes, we involved our child life specialists substantially once we got ourselves organized. Child life was a really big part of what we did and helped us develop all of the materials. Other emergency departments didn't have that, but in one emergency department, the unit clerk was the champion. And, she just was so passionate about this. And she referred to the rest of the staff as the girls. And she would say to me, well, I was talking to the girls today, and I noticed that there were a couple kids that didn't get their topical anesthetic. And, this was a unit clerk, but it was a small emergency department, and they knew each other well. And they were quite creative. And so the culture change, I think, will look different in different places. And, sometimes what works in a large site is different from what works in a small site, but it's not always that the large site has the advantage.
Thank you. There are a number of questions about bubbles. So bubble shooters are not approved by Doreen's infection control folks. And someone else has said they have a gun imitation kind of toy that blows the bubbles, but she's wondering if that's the most appropriate option. And the transition from blowing, anybody else transitioning from blowing bubbles in this time of COVID to other options. Do you have any suggestions for these folks?
Yeah, bubbles I find it almost ironically hilarious how contentious bubbles are across hospitals in Canada and the world probably. Some people are not allowed to use bubbles at all. Some people use them all the time. And I think you do have to work within your institution's regulations, although you can gently let them know that other places do use them if that helps encourage. I am not an IPC expert in any way, shape, or form, but soap and water seems pretty benign for all things that we put into the air in hospitals. So that's why, on a personal level, I thought it was comfortable. And then, of course, we did run it past our IPC, who said it was okay. The shooter shape of these things, the gun shape of these things, is not lost on me. The other options were like tabletop machines that had to be put in a room to blow, and they tend to blow quite a bit more bubbles, so more cost for the amount of solution, and also a little bit overwhelming in a 10 by 12 foot room to fill the room with them. So that is why we went with these ones where they dispense smaller amounts. But I'm quite certain as soon as we are able to return to some closer form of functioning that we had pre-2020, that our small bubbles might, like our handheld bubble ones, will likely return. So I don't have a good response to the fact that they look like guns. You're absolutely right, and it wasn't lost on us, and we thought about it and then considered it a weighed risk-benefit scenario. Yeah.
That makes sense. Emily has asked, do you see an initiative like this being feasible for a province that doesn't have a provincial health authority?
I'm going to see if Jennifer or Elise want to tackle that as our knowledge spread and QI experts.
Can you repeat that question again?
Oh, sure. No, I have to go back to it now.
It was around feasibility of spread. Oh, sorry, go ahead, Paula, if you found it.
Do you see an initiative like this being feasible for a province that doesn't have a provincial health authority? I'm assuming that might have been a promotional, like a positive factor in implementation, but is it necessarily a required condition?
I don't think it was a requirement. It helped us certainly in establishing the initial communications that we certainly had all the contact information for everyone. But once we had the sites on board, the fact that we were all part of Alberta Health Services, I don't think really mattered. Where it was helpful was it was very easy for me to be able to tell the sites, here's your list of 10 fracture patients and 10 blood work patients for you to audit your charts. But if a site could locally identify their own charts for auditing, and if contact information could be collected alternatively, there was really no other factor related to being part of One Health Network that was critical. So I do not think that it would be necessary.
Great. Where did you report your QI findings? Liz wants to know. Was it at departmental meetings, or how did you share that across the institution?
Well, I think it was first of all, most important to share within the emergency department, because if we were actually meeting our aims and improving, it was really inspiring and really helped with culture change. That principle of creating early wins. People get excited when things are going well. So sharing it within the ED, whether it was just our ED meetings or sharing on the floor with even like posters and things like that. That was super important. We do have a hospital quality council, and we developed a hospital-wide pain committee that we didn't have in early days. And so we did share at a hospital level and at some of our local QI conferences as well as national and international meetings. So in multiple different venues. I would say sharing within the ED was the most important, certainly for culture change. And we've really been able to enjoy sharing this in other settings as well.
Great. Gail wants to know if you encountered children who were already presenting with needle phobia from previous experiences, and how did that change your approach?
Three words: child life specialist. Right? We are so fortunate certainly at the Stollery for our implementation. That would be a child that, of course, we would start with the comfort plan, asking them what worked. But that's where our child life experts just this is where they are so integral to their input is so integral to the plan. Right?
And I'll add to that, our child life specialist will allow us to refer to them and for families to self-refer outside of the context of a visit. So if there is a child that is identified during a visit that has a needle phobia, we'll do everything we can to make it a positive experience, including even in some rare cases, even using things like nitrous oxide when really a child is struggling with that needle phobia. However, our child life specialists will see these kids outside of a medical context, which is really wonderful because they can come to the hospital knowing that they're not going to have a needle, not going to have a procedure, and have a really positive experience with child life. And I don't even know all the details of the magic that they work, but it's really wonderful that we can send these kids to child life for a visit when they know that they're not going to have a needle procedure.
Great. Let's see. Were there any, Anna wants to know, were there any barriers identified with compliance of documentation, particularly with regard to pain scales? And if so, what were they and what helped?
I can give a really honest answer here. We started out with documentation of pain scales as the first thing that we were looking at, and we had a hard time getting engagement behind it. We moved on to looking at a proportion of families that were dissatisfied with their pain experience. And we were able to get that down to pretty close to zero, like under 5%. We have not yet improved our recording of pain scales. And I talked to triage nurses and they said, if I have to navigate through 3 or 4 screens to put it in, do I really know that this information is going to be useful to the next person who sees the patient? If you're asking them anyway, they had reasonable perspectives. We didn't focus on that. And I'm not saying that we shouldn't. If we were in a US hospital, every single patient for sure would be getting pain scores. Some places, I know Sick Kids does a great job where they're at like almost 100%. We chose to focus on other things, and I would love to get back to a place where we can do that more reliably. But we chose to not focus on that measure, despite knowing how important it was, because we actually saw that our triage nurses were assessing pain. They weren't always documenting it.
Yes.
I'll just add to that.
Yes,
that's the biggest. The biggest lesson we've learned doing research in this area as well is that the documentation in most Canadian sites is 5 to 10% in the studies we've done. But when we do the qualitative work or the observational work, the measurements, as Jennifer said, is much higher. And the only solution I've seen effectively solve this problem is implementation of an electronic medical record that doesn't let you proceed to the next step until you've entered a pain score. That's how you get it.
Forced choice, yes. A couple of questions around how you financially supported paid and protected positions, and what FTE of child life specialists do you have in the Emerge?
So at the Stollery, we are so fortunate that we are a SKIP, Solutions for Kids in Pain hub. So we had funds to hire a knowledge broker for all things pain, and this commitment to comfort reimplementation became one of the key projects that Dr. Ryder's taken on. But before that, when we did the first implementation, we went to somebody within our nursing administration who had protected time for education and QI, and said, can this be one of your projects? So our work actually became to convince our leadership that this was worth investing their paid individuals' time into. And when we were successful with that, then they joined the team. So that's how we got around the funding. The child life specialist question is a great one. The first implementation, we had maybe 8 hours a day, 5 days a week, because it was roughly one person equivalent that we had. And even that was contingent funding. So that's why we had to have all these alternate considerations and alternate access to toys and distraction kits, because there were so many hours when child life wasn't present. Currently, we probably have about twice that coverage, but we're still not at 24-hour coverage. And that's our dream and our goal in the distance, in the near future, is to get to that point.
And did you develop a business case to share with leadership to advocate for this? And is that available perhaps as we update the pain toolkit?
I'll perhaps let Jennifer or Elise speak to that, because they do a lot more paperwork than I do in this regard.
We do not have a formal business case. We've had conversations with our site leadership. We didn't have to have a whole lot of conversations, because we're fortunate that our site leadership has been extremely supportive of the work that we're doing with pain. And in terms of how that has affected our site, 'cause I have seen there's some questions about spread to the site. The thing that we spread was the fact that there was a program that tied everything together. We didn't try to specify what every area of the hospital would do, but we pulled all of the great work together into one committee, and that committee has close communication with our site leadership. And perhaps the reason that we don't have a formal business case is that we have been lucky to be all on the same page in this area.
Wonderful. There are a number of questions remaining, but there's a few, and we're getting out of time, so this is going to be the last question we'll take on the webinar, but I will share the questions with the three of you. If you're interested in providing some feedback, we could put it on the Knowledge Exchange Network. But the last question relates to the spread of commitment to comfort in other areas of the hospital, like NICU, PICU, PACU, and ambulatory surgery, other inpatient areas. To what extent have you spread, and what were the challenges?
Yeah, maybe just elaborating a little bit on what I was saying. So the name commitment to comfort came from the emergency department, the idea to have a philosophy that tied everything together, but there was already great work happening across our site. So yes, some of our tools were spread directly, but we also adopted things that were being done in other areas. So I think what was really successful for us was to not say, like, hey guys, we have this figured out, let's spread to, let's spread this everywhere. What we did was we formed a committee that was where there was representation from all of the areas, and the people in the NICU shared what they were doing, and the people in the PICU shared what they were doing, and Child Life had their hands in everything. So they, they certainly are kind of they're really a big part of our pain committee. Our pain specialists, both nursing and physician, are on that committee. And so having everyone talk to each other and work together, and we can all learn from the strengths of the various areas and then put it together under one philosophy. So I always, when people ask me, did you spread the commitment to comfort throughout the hospital? I always hesitate to answer that because it's not a quick yes. We spread the name and we spread the idea of having a philosophy. But what we really did was we worked with all of the areas so that we could collaborate and figure out what was going well and what we should, from each area, what should be spread throughout. And we identified areas that maybe needed a little bit more help and support. And the fact that we all came together, we were able to figure out how to get support to those areas.
Great. So that's the end of our time today. Thank you, Samina, Elise, and Jennifer, for sharing your time and expertise with us. Thank you to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization. Join us on February 17th at 11 a.m. Eastern when we bring you Imagining the Invisible, Lingering Brain Dysfunction After Pediatric Concussion. And join us on March 25th for our virtual complex care pop-up called All In, Creating Synergy for Pediatric Complex Care. To register or for more information, please visit childrenshealthcarecanada.ca. It's always great if you watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Samina, Elise, and Jennifer for this presentation, and to Skip for its support. And hopefully we will see many of you back here next week. Bye, everyone.